Thanks for inviting me to talk today. So yes, my name's Vales. I'm a clinical scientist at the Functional Gut Clinic. Started working at Guy's and St Thomas's in 2011 and moved to the Functional Gut Clinic about 4 years ago. We're providing services Peterborough, Coventry, and also a few trusts around London as well. And I think a common theme that you see across the different trusts that you go to is that these patients have the endoscopy, they have the barium, but there's still quite a lot of questions left unanswered. And obviously we want to try and produce a good report that's going to help the referrer dictate the treatment pathway. So what I want to try and do today, if possible, is give you a template of reporting that's going to work for the simple traces, but then that you can also use on the more difficult ones as well. Cover the Chicago classification, but obviously some of the criticism there based on the fact that it's only on 5 ml swallows. So I'll try and give you some insight in what you do in the cases that don't really go well with the criteria. So I'll do quite a quick overview of the basics of HRM. I'll cover the Chicago classification in terms of the parameters and how you would use that in the report. Oh. Sorry, 1 second. Oh,
Yeah, that's fine. So sorry, we're just going to give 2 seconds. We need to bring some microphone equipment in for the video, guys. Give them this chance to sort that out as well.
So you want another one like this one?
Oh, okay. Yeah. Cheers. Okay, much better. Excellent, perfect. So, yes, I'll go through the basics of HRM. I'll then talk about the Chicago classification in terms of the parameters and how you would apply it in the report. I'll go through some example traces so you actually can see the major motility disorders. I'll talk about the adjunctive test, which is going to be key when you do come to those more difficult traces. And then hopefully there'll be time at the end just to look at a case study. So this is esophageal manometry. You're getting this topographical colour plot from the entire length of the esophagus, simultaneous data at 1 centimetre resolution. And the high pressure regions there in red and the low pressure regions in blue. And sorry, 1 second, sort of need to sync these up. Distance on the y-axis, so pharynx at the top, stomach at the bottom, and time along the x-axis. The scale there on the right-hand side, usually the software defaults at about 150 to 200 at the top end, and 0 to -10 on the bottom end in terms of millimetres of mercury. It's not 100% important as to where exactly you set this scale, as long as you can see the normal range. But I think what is useful is if you can set the isobaric contour. This is the black line that you see surrounding the peristaltic wave. And that contour, just like a geographical map, will surround any pressure greater than what you've set on that scale. And this will give you a good idea of weakness of the contraction. It'll also give you an idea of any peristaltic breaks, so fragmented peristalsis. And you can also get a look at any compressions, or if there's resistance, or sometimes compartmentalized pressurization, so from a hiatus hernia. And that's doesn't really matter how you set the pressure range then, because that will always have you covered. When you are doing your trace, make sure you get a good landmark period. This will make sure that you can confirm where the anatomy is and everything's in the correct place. But also you need that for your resting pressure of the LOS. And that no swallows in between and a good 20 or 30 seconds between the swallows. So what is HRM showing us? Well, it is essentially just a pressure representation of the anatomy as it's working. So we can see the sphincters as they relax. We can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, we can see the esophageal body as it contracts. And the esophageal body as it contracts, essentially you can see the transition between the striated muscle into the smooth muscle. The resolution is good enough to do that. So from the striated into the smooth. And then the smooth muscle itself is further split into two sections dependent on its velocity. And the point in between those two is the deceleration point. And I'll go through the importance of that in just the next couple of slides. So, how do we measure these anatomical features? Well, probably the most important parameter in esophageal manometry is that of measuring LOS relaxation. This is the integrated relaxation pressure, or IRP. You can look at spasm in the esophagus if you're measuring the time between the upper sphincter relaxation and that distal the contractile deceleration point there, so that's distal latency. And you can measure the strength of the contraction by looking at the smooth muscle, and this is distal contractile integral, DCI. There are a few other parameters that you can look at, but these three are key, and we would say that you need to make sure you're accurately measuring all three of those parameters for every single one of the wet swallows that you're taking. Just to sort of drive that home, this is the end of the first part of the talk, which is just on the basics of HRM. Always make sure that you're accurately measuring these three parameters. Okay, so now you've got all your data, how are you going to put it into the report? Well, as I said at the beginning, we would recommend using the Chicago classification. This is going to give you the parameters that you need. The best way to think about it is if you can imagine a sort of pyramid with anything that affects outflow obstruction being at the top and progressively less severe disorders all the way down to normal at the bottom. So, on that basis, with disorders at the top trumping those at the bottom, we'll do a esophageal dysmotility top trumps. So right at the top there is the parameters that affect both peristalsis and IRP. So this is where we get impaired relaxation. They are grouped together at the top and differentiated by whether or not there is normal peristalsis. So that is, if there is not abnormal DCI or abnormal distal latency, that is achalasia, and these are the top trumps. The next one down there is if you have normal peristalsis, so DCI and distal latency is normal, then this is just outflow obstruction. Moving down, you can see that now IRP is normal, so LOS relaxation is okay, but DCI and distal latency is impaired. Donald there, you can see, is still pretty unhappy about these. So even though LOS relaxation is normal, this is still considered a major motility disorder. And then if we move down, you've got the minor disorders, potentially questionable as to the relevance. It's going to depend a lot on the symptoms and the history. And as you can see, Donald doesn't really know what to think about these. And then if none of those criteria apply, it's normal motility. So that is the Chicago classification, version 3. And this is how the table will appear in the article if you get a chance to read it. And I've just added in those extra markers there to make it easier if you are applying it into the report. And what I'll do now is just go over some traces so you can see what they look like. So starting at the top with the disorders of outflow obstruction. Probably the most well-defined esophageal disorder is that of achalasia. We don't know what causes it, but it results in a loss of the signal from the brain to the smooth muscle, and this leads to a lack of LOS relaxation and a lack of peristalsis. There is no cure, so interventions revolve around trying to open up the OGJ and allow contents to go into the stomach. There are 3 types. This is classic achalasia, type 1. Abnormal IRP, so when we say abnormal IRP, we're measuring the 10 wet swallows and we're taking the median value. And so this is raised IRP and no contraction, so all swallows less than 100 DCI. Type 2, or achalasia with esophageal compression, again, raised IRP, but these repetitive panesophageal pressurizations. The pressurizations themselves have to exceed the 30 millimeter isobaric contour, and there needs to be at least 20% of swallows for this to be defined. And then type 3, again, raised IRP, but distal latency of less than 4.5 seconds, and this is in greater than 20% of swallows. Again, going down that pyramid, so the next one down, outflow obstruction. This is raised IRP, but distal latency and DCI is normal. And this is not achalasia. And whereas there is no cure with achalasia, we don't know what the cause is, actually, for OGJ outflow obstruction, there could be quite a lot of causes. It could be a tumour, there could be a stricture there, or even just mild inflammation. Eosinophilic esophagitis could be in play. And this is also something commonly that we might see with an opioid-induced dysmotility. So always ask your patients about any medications that they're taking. And obviously, you need to ask a good history, so have they had a RAP? Because that could be an explanation as well. But the main thing there, whereas with achalasia, there is no cure, potentially with outflow obstruction, you could reverse the disorder. And just so you can see it there, it could look quite subtle. You could think that actually motility looks quite normal, but IRP is raised. So moving down, we now get to the major disorders of peristalsis. Absent contractility is what it says, all swallows less than 100 DCI, IRP normal. Distal esophageal spasm, again, normal IRP in all of these. I've not gone that across, there we go. But distal latency less than 4.5 seconds in at least 20% of the swallows. And hypercontractile esophagus, normal IRP, normal distal latency, but a DCI greater than 8,000, and again in at least 20% of the swallows. Moving down, we now come to the minor disorders. And in the article, it does say that there was some debate as to the relevance of these. However, they include fragmented peristalsis. So this is where you have large breaks greater than 5 centimeters using the 20 millimeter isobaric contour. And this has to be in more than 50% of the swallows. And ineffective motility, a DCI of less than 450, and again in more than 50% of the swallows. The term ineffective comes from that statement there, impaired bolus transit. And essentially the idea is that in swallows less than 450, there was an increased chance that you would get bolus escape or poor clearance. However, overall, it's potentially not the best way to describe the motility. The problem comes is if you're sending that back to the referrer and telling them it's ineffective, you've got to ask yourself, is that really a good description of what you're seeing? So there are a few ways you can get around this. If you have access to impedance, you can see that the bolus has actually been cleared. The swallow on the left there, it's weak, and there's a little bit of a gap at the bottom, and that's where the bolus has escaped. Whereas the one on the right, still weak, still less than 450 on the DCI, but good clearance. So you could then say that actually overall motility is effective. But probably the best way you're going to do this is if you can use the adjunctive tests. This is going to reveal the peristaltic reserve and prove that the motility is normal. And it's also the best way to reproduce symptoms in the patients. If you're doing the 200 ml rapid drink challenge, you're going to further assess IRP to see how the OGJ is relaxing. And if you're using the multiple rapid swallow, you can further assess peristaltic reserve. There's a good review of the water-based adjunctive tests in the Lyon consensus there. So that's what you want to see if you're doing your 200 ml rapid. A really good relaxation of the OGJ and really clear that it's relaxed quite well. In this study by Ang et al, they were able to show that in this situation using the Sierra system, you want an IRP of less than 8 millimeters of mercury to show that it looks okay. If it's greater than this, then it could be a suggestion that there's outflow obstruction. A useful way to use this is if you're getting multiple interventions for the patients, or if they're being done by sort of progressive dilatations, you can then measure and compare in between the studies that you're doing. And just to give you an idea, this is a sort of a classic achalasia case where potentially it might not have been too obvious on the 5mm swallows, but then this would give you the confidence. You can see no LOS relaxation, big pressurization in the esophagus, none of it's getting through, so just building up there. If you're doing the multiple rapid swallow, this is making use of the post-agglutinative response, so you're performing multiple swallows, rapidly initiated, and you're sort of building up that neural response, and then when you stop swallowing, it will then release this heightened contraction. The way you want to say is if it's successful, is if the DCI of that contraction is higher than the mean DCI that you've seen in the 10 wet swallows. And conversely, an absence of the contraction could suggest that there is increased risk of dysphagia when they go forward for anti-reflux surgery. And it is the most common feature in scleroderma. However, just be careful that if you are going to report that there's been no response, the authors suggest that you do it at least 3 times. And then the last, oh, no, it's not going fast. The last type of adjunctive test is using the solid swallows. Normal values for using a 1 centimetre cube piece of bread have existed for quite some time. And that review at the bottom there by Carlson and Roman will give you a look, they look at studies that were done on bread swallows, on the viscous swallows, and on rice as well. And I think it's that latter one that is going to get you the biggest bang for your buck. So doing the rice, sort of the easiest way to achieve the most that you can. They took normal volunteers and symptomatic patients as well, and gave them 200 grams of rice, and they were able to get normal values for the IRP, DCI and the distal latency, so all 3 of the key parameters there. It was more readily acceptable to the patients, and there's less allergies associated with rice. And supermarket bought, whack it in the microwave, it's ready in a minute. So before I go over the case study, just to sort of recap, make sure you're identifying your 3 key parameters for all swallows. Make sure you're using the Chicago classification to get your diagnosis, and then confirm the diagnosis with the adjunctive tests. Hopefully, what I've shown is that if you use these 3 things, you can deal with the standard traces, but with just a few tweaks, I think you can also use it for the more difficult traces, and that's what we'll go through now. So it happens to me, I'll see something that I wasn't expecting, and I think, well, how am I going to report on this? And I think the main thing is that there's no point during the second swallow of the test trying to think, oh my God, what am I going to write? Start from the basics and build up. The rest of it will take care of itself. Follow the template, your 3 key parameters, follow the Chicago, and use your adjunctive tests. And get as much information as you can. Get hold of the history, the bearing, and the gastroscopy are going to be the most important. So I'm just going to read through this. 25-year-old female, low dysphagia with chest pain with every meal. Some reflux symptoms as well, but basically a history of about 10 years of achalasia. I'd had the myotomy and a fundoplication. The symptoms of dysphagia and chest pain had gone so bad they actually reversed the wrap. Multiple dilatations in between all of that, and then to top it off, she even had Ehlers-Danlos syndrome. The previous manometry done a few years ago, unfortunately, was curled, so that didn't really show anything. And time bearing swallow done just before the trace showed that there was a no column after 1 minute, so suggesting that actually outflow is okay. And that is what we got with the 5mm swallows. So that's when I panic. Is this the lungs? Have I intubated a guide dog by mistake? No features of the normal anatomy, I'm wondering where I am. But start from the first principles. You've got to remember that if you've taken a history and they have had a myotomy and it was 10 years ago and they've had multiple dilatations, you're probably not going to see anything of the normal features. get them to take a massive, big, deep breath in. At least you can identify where the diaphragm is. That will tell you that at least you're not curled and that you're through into the stomach. That was the 200 mil. So not as clear cut as the trace that I showed you before, where there was obvious pressurization, but still something going on. If I go back one, you can sort of see that the diaphragm is at about 44 centimeters if you look at the scale on the right. And this resistance happening at about 39. So then we start to think, is there a hiatus hernia or something at play here? And the solid swallows, similar to the fibril swallows, just these random focal compressions just happening intermittently, but nothing else much going on. It's in this situation where you can actually go back to the beginning of your cycle. You've gotten the other tests from the barium and from the OGD, and they've given what the report that they can. But you've been, by using the manometry, you can see something that they haven't seen. So in this situation, we actually went back to the radiologist and said, could you have a look again, you know, in this specific spot? And indeed, they were able to see some narrowing there. And the conclusion was that this is a bit of spasm that was left behind by the myotomy. So for 10 years, this lady had essentially remnant spasms going on that no one had seen. And then the plan to go forward with an OGD and just assess the possibilities, dilatation, Botox, or even POIM. So I think that's essentially giving you the idea of the three key things: your adjunctive tests, your Chicago classification, and also just getting involved with your colleagues and definitely asking questions, sending information back, and that should cover you for even the most difficult traces. Thanks very much.
Thank you very much, Andres. Just before I open the floor to questions, I'll just compliment Andres' talk with a few points, because I appreciate there's some experienced people here, but there's probably some people who are fresh to it or have just recently started. So I think when we're talking in terms of the Chicago classification, we have to bear in mind these are for patients who've had no intervention. So, you know, there's no point saying there's a raised IRP, the integrated relaxation point, if they've had a fundoplication, because that's normal. That's the whole point of having a fundoplication, is to create that residual pressure. And I thought your case study was really good, and you showed where the diaphragm was by a big deep breath in. And in our unit, and I'm sure some others as well, what we tend to do with everyone is do a big deep breath in at the beginning. Give yourself that quality assurance at the beginning that you cross the diaphragm. And also do a big cough. It sounds simple, but yet it's another quality assurance to check that all the sensors are working. And the scale as well, it doesn't really matter what you've got it set to. I've noticed it was 150, we do it at 100. I don't think there's necessarily right or wrong, but the whole point of the high resolution manometry is picture recognition. So once you've chose your scale, keep it. Don't change it on a daily basis, because you won't recognise these important features that we're looking for, really. And another thing to remember about the IRP as well is the equipment that you're using. If you use an MMS, if you're using Sierra, the catheters have all got different cut-off values. So just bear that in mind and make sure you're reporting it in terms of the right equipment that you're using. And I think a few of those different little things should help a great deal, really. So that was a great talk. Thanks, Andres. Can I open the floor to any questions we have, please?
Just say, barium swallow reports notoriously come back saying there's an element of dysmotility. And often I've sent these patients for oesophageal manometry and it's been fine. So how reliable are barium swallows?
Not particularly. So you see this a lot, the tertiary contraction. Oh. Yes, sorry. So yeah, not particularly. You see this a lot in the report, the tertiary contraction. So the question there was when the barium starts to comment on contractility, and I think it's essentially similar to that reflux question that Rami was talking about before. They're looking at anatomy and the body of the esophagus. They can't talk about reflux or motility.
Yeah. There's a question.
Yeah, go ahead.
Where would you suggest you set your gastric baseline? Because the gastric baseline will be important for the IRP.
That's right. So it's a good point there that the software will allow you to move a marker at the bottom of the trace that essentially sets your gastric baseline. And the IRP will be calculated based on this. So try not to have it over You can see sometimes, especially in a fasted patient, some of the MMCs coming through in the stomach, so try not to have it in any contractions. Try and sacrifice the pharynx to have a good bit of the stomach at the bottom there, because again, your IRP is the most important parameter, so it's better to have less of the pharynx and more of that stomach so you can get a good place to position it. And essentially, yeah, you're looking for a place that is free from any sort of compressions or anything that looks abnormal. You just want that baseline resting gastric pressure. I think Rami had an additional point.
Sorry, there's one more point to make. So who asked that question? Hi. The standard is 3 centimeters beyond the distal marker. However, there is possibly pressure zones within that. So we have to make sure it's within a low pressure zone, because ultimately the IRP, which is the esophageal gastric pressure gradient, will depend on the gastric pressure. And so we want to identify the right place. Now, there's also the other caveat of whether or not you have a Heinz hernia. And if you've got a big hernia, whether or not you put the marker within or outside of the hernia. So it's ideally it should be outside. If you've got a very big Heinz hernia, like 6 centimeters, and you should be distal to the intrinsic lower esophageal sphincter by about 3 centimeters, it's not uncommon to place the gastric pressure marker within that hernia. But if you've got a small hernia, with less than 3, then you place the gastric marker outside of the hernia. But usually it's 3 centimeters is the default, distal to the distal end of the intrinsic lower esophageal sphincter, unless otherwise.
What about in obese patients who are raised?
Well, I mean that's different. Absolutely, and we have to put that
to the speaker.
Yeah, I think that's a problem as well. I mean, I think obviously in obese patients, or even those with stomach interventions, so gastrectomies and sleeves and things like that, they're more prone to reflux anyway, so that's the whole point. It is going to be difficult. I think you use your eye, use your 30 millimeter isobaric contour. So if IRP has been essentially made abnormal because of a pressurization, or even normal when it should be abnormal because of a pressurization within the stomach that's sort of offsetting it, then you need to use your eye, use the 200 ml rapid swallow. If you can see that there's pressurization there happening, a buildup of the water, but your IRP is coming out normal, I think you can then say, okay, IRP is normal. However, subjectively, using my experience and applying that to the report, I think there's some sort of pressurization there. And you could always then say, you know, potentially you would go forward for looking at a barium or time barium to assess any actual outflow problems. With solids.
Thank you very much. Andres?